First of all, I'd like to thank to the Wilson's disease association, especially Faustino, also the foundation of Amor Alert. Can you hear me? Can you hear me? All right. Okay, thank you very much. I was also Carmen Espinosa for being here, and my colleague from España, Luis Peña-Quintana. Well, I think that what I might repeat, I might try not to repeat what my colleague said, unless I get this bell, the sound of this bell. Okay, about 1 in 30,000 prevalence, 1 in 90 carriers in the Gran. This is the important prevalence in the Canary Islands. What is the age of onset? Well, when the copper accumulates. And when is that? When complementary feeding, and we're talking about 6 months of age. So this is very early, and a very early onset. Okay, the copper, we only need a small amount, that it's eliminated through the bile in the liver. This copper, it's needed for our body, and the patients, it's toxic because we have more than we should need. A person takes 1 to 2 milligrams a day, and most of it's eliminated in our bodies, and about 0.75% of maintenance. So what age do we see the Wilson's disease, age of presentation? So 3 months old in our series, very early. So it's rare, its presentation after 5 years old, but we have to screen the Wilson's disease, basically, and we should do that. So what is the metabolite that we should be studying? There are some 9 months old children with some of these manifestations. So we could have a presentation of advanced forms of Wilson's disease in children. What is the clinical manifestation? We're talking about children, and they are not mini adults. They are different. This is not a preschool children. So the presentation, the way of presentation, the mode of presentation is different actually in children. So we might have elevated transaminases and elevation because the hepatocytes in the liver are destroyed, and we get elevated transaminases. So any children with elevated transaminases, we should discard the Wilson's disease. So these children are okay, they just have elevated transaminases. We have to think about that. Or maybe family studies as well. The children maybe could have a acute liver hepatitis, or maybe hepatomegaly, fatty liver. So we should be aware, because these children might have fatty liver, MASD. So this fatty liver condition, we have to rule out. We might have to rule out basically Wilson's disease. We might have portal hypertension with esophageal varices, or decompensated cirrhosis with ascites. It would be very rare to have acute liver failure, although we have seen some 6 to 7 year old patients. We've seen that actually. So we must diagnose very early these patients, because we can't do that. The acute liver failure might be complex because the ceruloplasmin, it's an acute phase reactant, and these can be abnormally elevated. Maybe we are ruling out a Wilson, and then it is actually a Wilson. So especially if we have patients with jaundice. Also, it can be associated sometimes with hemolytic anemia, COMS negative. Sometimes when we diagnose these acute liver failures, we might have we might have some other AST/ALT inverted as well. So when the bilirubin is measured under 4, we might even suspect that we have a primary form of Wilson's disease. I don't know if you understand me. I'm gonna try to make my language of communication as late as possible. So sometimes, okay, over 50% of children can have some psychiatric or neurological manifestations. Most of them are because of this deposition of copper in the basal ganglia, but 5 to 15% show this in the pediatric age, and we've seen that with dysertia, tremor, dystonia, ataxia, rigidity, or juvenile Parkinson's. This is a meta-analysis, a publication, a systematic review, where we find that Wilson's disease, WD, is associated with alterations to movement or psychiatric impairment. So, okay, children might show a number of conditions or signs, okay, and this can be change of personality, poor school performance, behavioral changes, emotional liability. We think we have to rule out hyperthyroidism. These children might have some poor school performance, but we could even see dementia, bipolar disorder, OCD, depression, anxiety. So these would be within this screening, and they might be infradiagnosed, underdiagnosed rather. So this is important with the screening of a pediatrician with poor school performance and so forth. We basically should be doing this. Okay, case of Fraser ring. This does not. It's not just typical only from WD, but we can see sometimes cataracts as well, because of this deposition of copper in the eye. So we see that with neurological, and basically we should rule that out with this slit lamp at the opticians. We could also see tubulopathy, a Fanconi, and that's the kidney impairment, with hypophosphatemia, basically bone and joint manifestations, pain, osteoporosis, and arthropathy, and acute hemolysis as well. And this may be the first form of presentation. Also cardiac manifestations, cardiomyopathy, subclinical dysfunctions, arrhythmia, endocrine, pancreatitis, and also the skin lipomas, hyperpigmentation, and these can be manifestations of the condition as well. So this is basically the typical clinical manifestations. Patients with less than 10 years old, we will see hepatic manifestations, the elevated transaminases without any other symptoms, and in terms of the neurologic manifestations, they tend to be less frequent. We have here the different evolution actually, or 10 to 18 years and over 18 years old. What's our experience? We have diagnosed 36 patients with WD. We have 80-something patients with WD in the Canary Islands, and most of these pediatric patients are asymptomatic, and family history. We might have abdominal pain, liver failure, cholestatic hepatitis. A warning here, ceruloplasmin normal levels. This is an acute phase reactant. We have to check whether there is WD with time. Big developed neurological symptoms, extrapyramidal syndrome, dysarthria, dyslalia, language delay, paresthesia, blurred vision, behavioral disorders or educational delay, the case of KF rings as well. So this is our experience here over the years. The youngest 3 months diagnosis and the oldest 14 years old. The former, basically, we have a family history. Okay. Diagnosis, I will not deep dive into that because our colleague explained that, but basically we'll be looking at blood ceruloplasmin, serum copper, total not bound to ceruloplasmin, the interchangeable copper as well, copper in urine, copper in liver tissue, liver biopsy, and genetic study in some of them. Right now, we are performing the molecular study. Thank you very much to the La Palma team, Professor Tuore, Carmen Espinoz. We have high prevalence because we have a mutation that I will explain. We saw these children from a Pakistani background that they're living there, and this is not a de novo mutation, but it had not been diagnosed previously. So these are the Leipzig criteria, the steps that have been previously explained. Maybe as a different update today, it's quite popular, the ATP7B peptides. We are studying them. I think the microRNAs as well. We have collaborated with Carmen Espinoz with a study with children, neurofilament light chain, NFLs, and so on. And maybe we should think whether this could be the newborns screening. We cannot measure the ceruloplasmin because we start to produce ceruloplasmin from the 7th or 8th month of age. So we should, why should we screen WD? We have to screen as much as we can. Basically, in the Canary Islands, we'll have about 50 conditions to be screened off. So you know that there's a difference in the different regions in Spain, but we're screening for absolutely everything we can. But obviously, from a cost-effective point of view, it needs to be a significant health problem. Yes, it is. You're all here. Do you have a known natural history? Of course, we have pathologists, adult patients, pediatricians, researchers, and go on. Does it have a generally long latency period? Yes. Effective treatment. So we have to basically screen. If we are screening that, we are able to study all these signs and symptoms. So I urge the researchers to continue following on this line. Ceruloplasmin can be measured, and we expect to do a population screening, general population screening from 4 years of age. In 2000, Luis García Villarreal published this study with a high prevalence of Wilson's disease gene mutation, and this had been described previously, LEU 708 par IO, 24 patients from 17 families with this mutation, highly prevalent in the Gran Canaria island, 1 every 2,600, and in a specific area of the island. So we carried out this study in children later on, and funnily enough, children also carried this mutation, L708P, homozygote, and also in another joint publication with all these patients, we have 70 patients, we have even more, diagnosed only in the island of Gran Canaria with a global prevalence of 1 every 12,369. In this area, 1 every 28 carriers. So you can see the high frequency in the Canary Islands. Why do we have that high incidence? Remember that this is the more frequent in Gran Canary Islands, 75% in the Canary Islands. And we are very proud of being Spaniard. So remember, this is Lanzarote and natives to Gran Canary. It's not found in the other islands or on the Spanish mainland, together with some areas of Greece or Sardinia, also part of Sardinia as well, another island. Estimated age, 56 generations, and it comes from the pre-Hispanic that stayed on the island. So this population, basically this is a recent publication about how they reached the island between the centuries 1 and 3 AD through the Berber population from West Africa. This is how they reached the island. This is a facial reconstruction of these natives that were found in the Canary Islands, and this was made by the John Moores University in Liverpool. These mutations, 708P, is the second most frequent in Brazil. It's very frequent in Costa Rica and Cuba and in the USA. In other Latin American countries, we don't find that because we haven't measured it. These were the native Canary sort of mixed with the Spanish conquistadores, bringing the mutation to the New World. Okay, some anthropology and history knowledge here. Okay, low copper diet, but this is part of the treatment. You cannot live without copper, absolute copper at all. So we have to adapt the diet, except seafood and viscera as well, or solid organs as well. We check the zinc salts as well, and we blend the copper and the zinc salts, and we try to adapt. So we use the trientine as well with the new drugs, new forms. We use it depending on the cases. These tend to be quite expensive drugs as well, and we have tetramolybdate. There was this clinical trial carried out with our patients, and basically it was not efficient enough, and that is not in the market anymore. Obviously, we have the liver transplant and the gene therapy. So this is the full umbrella of treatment. We use these for children with a single therapy, zinc salts. Many of them get to adulthood only taking zinc salt. In other stages, only with penicillamine, have moved to trientine, and so we have different patients. We start with penicillamine, and then we might move to zinc salt. So it depends on the experience. Okay, prognosis without treatment, we have fatal outcome. For presymptomatic patients, the transaminases normalize within 1 to 2 years. If they do not, the main cause is that they do not take the medication, they hide it, they do not tolerate well, especially if they are pre-teenagers or teenagers as well. This is quite frequent. If we have an advanced liver disease, 50% have a therapeutic response, and in other cases, for liver failure, we need liver transplant frequently. So they come to a hospital with the diagnosis, with their pediatricians, but a child with 17, 18 years old with a liver failure, it's quite sad to see that situation. What about the quality of life? This is a multicentric study that was carried out, and 102 patients, adults and pediatric patients. And basically we have these patients diagnosed when they are now 30 to 32%, and 30% of them show emotional deterioration with depression or anxiety, and only 22.5%, according to the study, have a good treatment adherence.
So, I know it's a hassle to have to take medication every day. Basically, asymptomatic hypertension is the most common form in childhood, that we need to rule out Wilson's and any chronic liver disease. So you need to rule this out. The presentation is heterogeneous. Signs and symptoms vary. Neurologic/psychiatric clinical presentation is underdiagnosed. Molecular test is the future, and move away from biopsies. We don't conduct biopsies so much because we have great geneticists who identify the mutation, and biopsy involves a syringe, and children require us using non-invasive approaches. These are the rights of children, and if we can, we need not to be invasive. This was bestowed by the WHO. Then early diagnosis with appropriate treatment and follow-up prevents the onset of complications. We need early diagnosis. This is a condition that has to be within the screening of our programs. We screen for 150 rare diseases. It's a cost-effective approach. And there are biomarkers that are being researched, the ATP7B peptides and microRNAs and else. And Carmen, we mentioned this. It's important to look for whatever is faster. I'd simply like to close by thanking the whole team, Luis, who's here with us, and the rest of the team members in the Canary Islands, so Antonio, Tugores, Ana Sanchez, Paloma Garay, Carmen Espinosa, and all. So the younger physicians, the oldest, and well, this is the team. Some of them are here, others are not. So this presentation goes out to everybody who's helped, including the GI department and the... Anyway, thank you. Thank you all very much for listening.